All right, welcome back everybody. Let's continue on with part 2 of our patient assessment lecture. So just a quick review. Let's talk about the 4 kind of major points that we have when we're discussing our scene assessment or our scene size up. So the very top one, if you're sitting at home watching this, real quickly just try to fill this in without my help. So I'll kind of give you a second. If you need to, you can review your notes, but let's go ahead and discuss them. So the first thing that we have up here is our scene safety. Again, we want to make sure that we're not going into a dangerous scene. We need to consider how to keep ourselves safe with our body substance isolation or our personal protective equipment. We need to know how many patients we have, and if we need any additional resources due to sheer number of patients or just a technical operation. And then we need to consider our mechanism of injury, and then the other one that we had down here was a nature of illness as well. Once we've considered all of those, we can also take into consideration the chief complaint of the patient. So why are we helping them right now? Why are they requiring assistance? After our scene size up, that's when we jump into our primary assessment. Again, the goal of our primary assessment is just to identify immediately and fix, if possible, these very immediate life-threatening issues that the patient might be experiencing. So I think something that I want to reiterate, if I didn't say it before, is that we don't move on from our primary assessment until we've addressed any problems that might be present. So again, the 4 points that we have with our primary assessment will be our airway. If there's a problem with their airway, we need to fix it right away. Breathing, are they having any difficulty breathing? If they are, we need to find a way to fix it, or we need to get them evacuated. And then circulation, we need to know if they're moving blood throughout their body. If they're not moving blood effectively, if they've lost a lot of blood, and we need to fix those problems. And then we need to, if we're not able to fix them, we need to think about immediate evacuation. And then kind of within this triangle that we have is level of responsiveness. And the reason why level of responsiveness falls on the inside of this triangle is because really any compromise of your airway or your breathing or your circulation can lead to a decrease in your level of responsiveness. So that's why this guy kind of falls in the middle. He can be affected by any of these 3 or a combination of these 3. So after we've made our, after we've done our primary assessment and we've made our transport decision, it's time to move into our secondary assessment. And so really this is when we're starting to get more in depth with our investigation of what's going on with the patient. So the kind of 3 different categories or 3 different areas of our secondary assessment will be our physical examination, our vital signs, and then our history of present illness and of medical history. So starting off with our physical assessment, this is a head-to-toe assessment. I'm not going to demonstrate this right now. This is something that we'll practice in our lab day, but I want you guys to take a minute to watch Dane's video of a trauma assessment, because within that he does a very good head-to-toe physical assessment, as well as the other components of the assessment. But head-to-toe, real quick, we're just doing exactly that. We're moving down from their head. We're looking for any injuries, any bruising, any crepitus, any bone crunching, anything like that. So we're starting with the head. We're looking at the eyes. Do their eyes look like they're okay? Do they look discolored? Are their pupils different sizes? Are their pupils really big? Are they really small? We're looking at the ears and the nose and the mouth for any blood, any trauma there. We're going to look down the neck. We'll talk about neck injuries and specific assessment of the neck later on in a different lecture, but basically you're going to feel down their vertebra one at a time. So the way that looks is starting at the top, we're just coming down and palpating each vertebra as we go. Feeling for any deformity, trying to elicit a painful response. So throughout this head to toe, we're feeling for anything abnormal, but we're also trying to elicit a painful response. If you're feeling around the head and all of a sudden you touch the back of their head and they go, ow, ow, ow. Well, that's worth noting. We know that they have an injury there. We know that there's some kind of wound. So that's certainly a goal of this physical exam. Moving down, we're checking the shoulders, feeling if they're stable, feeling the chest, making sure the ribs are intact, making sure, again, that we're not eliciting a painful response. We're then going to feel the abdomen. We're going to feel in all 4 quadrants, and the idea is that we're trying to feel for any tenderness, any distension, any rigidity. All of those things are abnormal findings. Pelvis, we're going to push on the pelvis, so you kind of push on both sides inwards, and then if they're laying down, you push downwards on both pelvic crests. Again, trying to feel for any instability or feel for any pain. We then move down the extremities, checking each extremity for any injuries, any deformities. And then we're going to feel all the way down the back as well. During our physical examination, we're looking for a number of different things, and this acronym up here, DCAP BTLS, helps us remember different things that we might be looking for. Deformity, so this might be something just looks deformed, it doesn't look right. Maybe if they have a broken arm, their arm is like bending in the wrong direction, that would be considered a deformity. Contusion is the medical term for a bruise, so we're looking for any bruising that might be present. Abrasion, this is like road rash or scrapes when someone's been rubbed up against a rough surface. Puncture, this is when something stabs into someone, so the wound might be very small, it might be very discreet, but it might go very deep into the underlying tissues. Punctures are of concern because we are worried about infection. They have a high rate of infection. Burns, varying degrees of burns that can be present. Tenderness simply means that when you push on it, it hurts. So that's certainly something that we're looking for in our physical examination. A laceration is a cut, and then swelling is pretty self-explanatory, but it's something that we're looking for during our physical examination. During our physical examination, we want to note the location and the severity of any injuries that we've encountered, and then as we start finding and uncovering more injuries throughout our assessment, we want to start, again, reevaluating our patient priority, and then also just prioritizing each and every problem. So if I find a small abrasion or scrape to their arm, but then I find pretty big deformity of their leg, well, the deformity of the leg is going to be higher priority than the small abrasion. As we go through our physical assessment, it's good to be asking questions simultaneously. So we can be asking about any neck pain that they might be having, any chest pain as we're palpating their chest, any difficulty breathing. As you're palpating their abdomen, ask them if they've had any abdominal pain. Again, that might prompt you to ask questions such as any difficulty in having a bowel movement, any nausea, vomiting, things like that. There's a whole slew of questions that you can ask during your physical examination, and I highly recommend maybe looking up online, seeing if you can find some good lists of questions to ask during your assessment. Extremities, pulse, movement, and sensation. We're going to talk a lot about this in our orthopedic lecture, but the idea is that in each extremity, we want to know if they have circulation and nerves intact. So the way you check, if I'm checking my left arm, I'm going to feel for a pulse. Okay, pulse is present, so there is blood flow. I'm going to feel for sensation. I can feel that. And then I'm going to ask the patient to move their fingers. So that signifies that they have a motor function of their hand. We want to check all 4 extremities. Something that I didn't mention before for checking circulation is a capillary refill. And so this is kind of a proxy for our circulation assessment. So maybe we aren't able to find a pulse. Sometimes people are just difficult to find pulses on. Maybe they have, for whatever reason, just not able to check the pulse. You can check what's called capillary refill, which is basically you're going to squeeze the nail bed until it turns pale. So you've pushed all the blood out of the nail bed, you let go, and you count how long it takes for their nail to pink up. And in general, it should be less than 2 seconds. A healthy adult that is moving blood effectively should have a capillary refill of less than 2 seconds. If it's greater than 2 seconds, it might mean that they are not moving blood effectively. So if their capillary refill is, say, like 5 seconds, that would be concerning. Recognize that if the person is cold, if it's someone's been sitting in the snow for a while, they're hypothermic, their capillary refill will be delayed. And that's just a normal physiological response to the cold, is that we don't move much blood to our extremities, and so that could cause a delayed cap refill. But if you don't want to check a pulse, if you're having trouble checking a pulse, it can be particularly difficult when checking on the feet. Capillary refill is a wonderful alternative. And then back, of course, you can ask the patient if they're complaining of any back pain. That's definitely something that we want to know. Moving right along, we're going to talk a little bit about vital signs. So this is something that we will practice in our lab session. It's important that you know how to take vital signs. How often should we take them? Well, that depends on the patient, depends on the situation, but in general, if the patient is critical, if we think that they're seriously injured, we really want to assess their vital signs every 5 minutes or so, if you're able to. If they're stable, if they're doing okay, they just have a simple injury, ideally checking every 15 minutes is good. Sometimes during an evacuation, you're just not able to assess that frequently, so you just need to be aware if you're prolonging it any more than 15 minutes, you need to have a reason why. Again, remember that the art of assessment is reassessment, so reassessing a patient's vital signs frequently gives us an idea of how they're trending. So are they staying the same? Are they getting better? Maybe their heart rate is coming down, their blood pressure is getting better, or are they getting worse? So are they becoming more and more altered? Are they having more and more difficulty breathing? That's why we need to reassess vital signs frequently. So a pulse, very simple. You're just going to locate your pulse, either your radial pulse or your carotid pulse. Again, we'll practice this. But you're just going to feel, you're going to need a stopwatch, and you're going to count for 15 seconds how many pulses you feel. You're then going to take that number and you're going to multiply it by 4. This will tell you their heart rate, beats per minute. And for an adult, for a healthy adult, the normal heart rate is going to be 60 to 100. So 60 to 100 beats per minute. Certainly, if they've been exercising, as you probably know, if you just got done running a couple miles, your heart rate will be elevated. But in a resting adult, this should generally be 60 to 100. If they're above 100, that's a little too fast. If they're above 120, then that's definitely cause for concern. Similarly, if their heart rate is too slow, if it's below 50, below 40, that's also very concerning. Now, you have to take this into consideration of the big picture. So if someone is sitting there talking to you and they appear to be healthy, they appear to be able to answer questions, and their heart rate is 40, maybe that's just normal for them. So these average numbers obviously don't apply to everyone. Someone like Lance Armstrong or a very well-conditioned athlete will commonly have a lower heart rate, lower resting heart rate. So for someone of that shape, a resting heart rate of 40 might be normal. So take it into consideration of all the other things that we've talked about. So the next thing that we want to measure is the patient's respiratory rate. So this is how many times they are breathing per minute. One easy way to do this is to count how many seconds there are between breaths. So you might look at their stomach. It's an easy spot to see if they're breathing. Their stomach will kind of bulge outwards. So you see one respiration start, they finish, and then you see their next breath. If you count 5 seconds between those respirations, then their respiratory rate is about 12 per minute. If you count 3 seconds between those respirations, they're breathing about 20 breaths per minute. So our normal adult resting rate for breathing is 12 to 20 breaths per minute. So you can then kind of extrapolate out a little bit. If they have more than 5 seconds between each breath, or less than 3 seconds between each breath, then they are outside the normal range, and that sign is then abnormal. Respiratory rate can be obviously bad, or it can be pretty subtle. So if it's very, very rapid, if they're breathing 30 times per minute, you're going to know it's going to be pretty obvious that that person is having difficulty breathing. Skin, we kind of already talked about that one, but skin actually does count as a vital sign. So again, we're looking at the color, temperature, and moisture of the skin. Level of responsiveness, we already discussed that one in our primary assessment, but by all means you would like to reassess it at this point in your assessment. And then capillary refill, as we discussed earlier, you squeeze the nail bed, you count how long it takes for the nail bed to pink up, and that is your capillary refill. Blood pressure, we're not going to really talk about. It's beyond the scope of this class to measure blood pressure, but just know that blood pressure is kind of our measurement of how well they're moving blood throughout their body. So if someone has very low blood pressure, then they're not able to, they're not effectively moving blood throughout their body. I mentioned earlier that we're going to use kind of some proxies to some different signs. So while we're not going to actually measure blood pressure, I realize that heart rate is directly related to blood pressure. So generally speaking, if someone has a very rapid heart rate, it's in order to keep their blood pressure up. If someone has a very weak heart rate, if their pulse is very weak, then we can start assuming that their blood pressure is going down. So usually around these numbers actually vary quite a bit. There's been some studies on it, but in general, we can assume that if their radial pulse is absent, if you cannot feel it, their blood pressure is right around 80 and probably a little bit lower. So then we know that their blood pressure is low, and that's a sign that they're going into shock. So we're going to use our radial pulse and our mentation as kind of our estimates on how well they're moving blood throughout their body. Here again is kind of a diagram showing the different locations of our pulses. So we can check in the carotid artery right along the neck, and we can also check right along the radius down here in the forearm. So again, we'll practice that in our lab session. History, so now that we've done our physical assessment, these are questions that we want to ask our patients. So two different areas within our patient history. We have our sample history, which is our signs and symptoms. So what's going on? Do you have abdominal pain? Are you feeling dizzy? Do you have chest pain? All those things are signs and symptoms. Allergies. Does the patient have any allergies to foods, to drugs, to insects or animals? All of that we want to know. Does the patient take any medications? Have they taken any medications today? So that's also very important. Did you take any pain medication because you injured your leg? Questions such as that. Past medical history. Do they have diabetes? Do they have heart problems? Do they have asthma? These are things that we want to know. Last ins and outs. This is very important, especially in the wilderness setting, because sometimes people don't eat and hydrate appropriately, but you want to ask, when was the last time you had anything to eat? When did you last have any water? How much water have you had today? Have you been mixing anything into your water, any electrolyte solutions? And then also you need to ask, when was the last time you urinated? When was the last time you had a bowel movement? If they haven't urinated for a long time, despite drinking water, that could be a bad sign, especially if they're in a hot environment and they've been exerting themselves. And then finally, down here at the bottom, events leading up to their complaint. So what was going on leading up to your injury? You might have already figured this out when you're assessing your ANO, your level of orientation, but it's good to get a very thorough history of the events leading up to whatever happened to the patient. So along with our sample history, we want to get the history of present illness. So the acronym here is OPQRST. So O, onset, when did this happen? How long ago did your abdominal pain start? How long ago did your chest pain start? Provokes, palliates. Does anything make it better or does anything make it worse? So an example might be, yeah, I'm having a lot of difficulty breathing. When I sit up, it gets a lot better. If I lay down, I can't breathe. I feel like I'm suffocating. So that's an example of provoking or palliate the complaint. Quality. Quality, radiation, these next two really apply to pain complaints. So what we're asking is, what type of pain are you experiencing? That's the quality. So is it a stabbing pain? Is it pinpoint? Or is it kind of diffuse pain? Is it kind of cramping? Is it burning? All of these are different pain qualities. And then radiation is, does the pain move anywhere? So yeah, so an example of this might be, yeah, I've got this pain right here in my upper right quadrant of my abdomen, and it actually kind of moves to my right shoulder. Or another classic example would be, yeah, I've got this really bad crushing chest pain that actually radiates to my jaw or radiates to my shoulder. So that's what we're talking about with radiation. So does the pain move anywhere else? Severity, on a scale of 1 to 10, 1 being nothing and 10 being the absolute worst pain you can imagine, how do you rate your pain? And then time. Time is a little bit different than the onset. We're not just asking when did this start. We want to know how it's progressed. Has it been kind of coming and going? Has it been consistent? Has it been getting worse over time? That's what we're asking with T. And then the last one that we can throw in here, U. Has this ever happened to you before? Have you ever experienced chest pain like this? Have you ever experienced a migraine like this before? We want to know if this is a reoccurring thing, because if it is, then the next question that follows that is, okay, so what usually makes it better? Or what has your physician told you in the past is the reason for this reoccurring abdominal pain? So by all means, U, has this ever happened to you before, is a very good question to include in your history. After we do our patient assessment, and again, this is a dynamic process that keeps going on, we need to make sure that we're documenting things. So this is absolutely an essential component of patient care. It's also important for you to remember what's going on, because later down the road, if you don't write it down, you're not likely to remember it. And then, again, it's a way for you to communicate with other providers. So one format for documentation is this D chart. So D is for dispatch information. This is if you're part of a rescue team that gets sent out. So if you're just outside in your recreation and you're not getting dispatched, then obviously you leave this out. But basically your dispatch information is what time you got dispatched and what your initial information was. So an example would be, say March 15th, 2014, 1,500 hours, dispatched for a 55-year-old male out in the Sandia foothills. Chief complaint, this can actually be kind of included in your dispatch, so you could say 55-year-old male complaint of abdominal pain. So these two together, usually really brief in your documentation, usually only a couple sentences long. History, this is when you have your history of present illness and your sample history. And usually this is when you include any events that the patient or a bystander tells you that happened leading up to the event. So basically this history is everything that's happened up until you get to the patient. The assessment portion of your documentation, this is the way that I usually do this is describing my first immediate, my initial impression of the patient. So upon arriving on scene, a patient was found to be alert and oriented. Patient was breathing without difficulty. Circulation was good. Skin was warm, pink, and dry. And then I might go into my vital signs and then any physical findings I had. Patient had tenderness of the right leg and swelling of the right ankle, and so forth. After assessment, we have treatment. How did you manage the patient? Did you splint the leg? Did you wrap them up in a sleeping bag to keep them warm? So any treatment happens here. You include it here in this part of your documentation. And then finally, we have transportation. What kind of decision did you make? Was it a litter carryout? How long did the litter carryout take? Was there a helicopter involved? Did you just help the patient hike out? All of this stuff falls into transportation. So in review, here's just kind of a nice slide that helps you remember all the different components that we talked about. By all means, this is a very, very brief introduction into patient assessment, but these are the points to hit for sure. So your scene survey, your scene size up, just remember we're looking at our scene safety, probably the most important one, number of patients, mechanism of injury, and then any body substance isolation, any protective equipment that we might need. Primary assessment, the goal here being identifying any immediate life threats, so life threats to your airway, to your breathing, and your circulation. And within that, we're looking at their level of responsiveness. Moving on to the secondary assessment, this is when we're really getting into what's going on with the patient. So our head-to-toe physical assessment, our vital signs, and then our sample history. And then finally, down here, the part that no one really enjoys but is important all the same is our documentation. So make sure that you're keeping some kind of record of what occurred so that you can refer back to that later. So as always, if there are any questions in regards to patient assessment or wilderness medicine in general, please post them to the discussion board and I will try to get back to you. Definitely on the website you're going to find some additional course resources, so make sure that you peruse those and look them over. And I look forward to practicing patient assessment with you guys in our lab portion. Have a good day.